Welcome to today's PerfectServe sponsored webinar on Lean Six Sigma. My name is Corey and I will be your operator for today's call. We have just a few announcements before we begin. Please direct your attention to your computer screen as we briefly go through how today's presentation will operate. Please note that you may need to zoom in and out from your browser if you don't see all the sections I mentioned below. In the middle of your browser, you will see a box containing today's slides. They will advance automatically throughout the presentation. Directly below the slides, you will see a Q&A box to submit a question at any time. Your questions will be addressed during the Q&A portion at the end of the presentation. On the bottom left-hand side of your screen, you will find a webcast help icon for technical assistance, as well as a resource list containing a PDF of today's slides and a few other helpful resources. Also, along the left-hand side of your browser, you will see the idea wall. This is where you can give us your ideas for future webcast topics. Tell us what you want to learn more about, and we will do our best to deliver. And finally, to the right of the slides, you will see all tweets coming in about today's webinar. If you hear something worth tweeting about today, please reference hashtag PSWWebcast. That's without the letter S at the end in your tweet. All tweets are visible via the Twitter feed located to the right of the slides on your screen. If you are on the phone line but are experiencing any technical difficulties accessing web portion, please let us know by sending an email to webinars@perfectserve.net. At this time, all participants are in a listen-only mode. Please note that this conference is being recorded. At the conclusion of today's event, we ask that you complete a short survey that will appear on a separate browser window. Please disable all pop-up blockers to ensure that you receive the survey window. I will now turn the call over to Leanne Myers of PerfectServe. Leanne, you may begin.
Welcome to PerfectServe's Thought Leadership Webinar Series. I am Leanne Myers, Chief Clinical Officer at PerfectServe. We know that many of you on the line with us today are working hard to improve physician communication, reduce readmissions, and improve patient care. This is done through efficiency and removing waste from processes, which is why I'm so excited to have someone who not only has an expert knowledge of Lean Six Sigma, he's seen firsthand the impact it has within the walls of the hospital and private practice groups. Before we turn things over to our key presenter, I do want to take just a few minutes to introduce you to PerfectServe and how we help hospitals and health systems and practices streamline and optimize their clinical communications. Research has shown that communication breakdown is the primary contributor to delays in treatment. We recently commissioned a survey with Harris Poll and asked 1,000 healthcare professionals for their insight into the role of communication in the new world of population health management. You can see some of the survey results here. Many of the status quo tools and technologies of today fail to address the complexity inherent in today's clinical communication processes. PerfectServe Synchrony unites physicians, nurses, and other care team members across the continuum and facilitates timely interaction among them. Synchrony enables communication-driven workflows that facilitate timely care team collaboration and ultimately reduces the time to treatment. Visit us at perfectserve.com to learn more. One last item of note before I hand things over to today's speaker. By attending this PerfectServe sponsored webinar, you will receive continuing education credit from MGMA if you are a certified medical practice executive, CMPE nominee, or FACMPE. If you would like to receive a personalized certificate of attendance after today's webinar, please let us know via the survey shared at the end of today's webinar or send an email to webinars@perfectserve.net. After receiving your certificate of attendance, you must log your own credit hours on mgma.org. In today's webinar, we are learning about Lean Six Sigma from a master black belt and a nationally recognized medical practice management consultant, Owen Dahl. With his experiences presenting at multiple MGMA conferences, serving as a hospital administrator for over a decade, and consulting for over 49 years, Mr. Dahl will be sharing his firsthand observations on the impact Lean Six Sigma can have in a group practice setting as well as within hospitals. We are grateful to have Owen with us today. Thank you for joining us today, Owen, and I'm now going to turn things over to you.
Well, thank you very much, Dr. Myers. I appreciate that, and I want to welcome everyone to our session today on using Lean Six Sigma to optimize your medical practice operations. And I think that's key there because when we talk about this, we really want to talk about optimization of improving patient care. And that's what this is all about. So our program, we're going to define and kind of go through the principles and some of the tools. And as we go through that, we'll be talking about applications that we've seen and that can be used with the tools that we talk about, and then share some of the outcomes. And one of the key things on this is that we recognize that the idea of Lean Six Sigma and improving patient care really starts with you as the leadership of our organizations, but doesn't come from you. And by that, what I mean is that we have to look at what our customer wants, and I use that term advisedly because we need to define who our customer is, as well as looking at how do we do this with our team. And our team is our staff members that we have and are involved. And what we also need to think about is the idea of what's our culture like. And right now, everybody thinks about this as nothing but rapid change. And, oh, by the way, I forgot to mention this. Happy ICD-10 Day. I hope you're all celebrating and having birthdays, parties, and cakes and balloons, and are all really excited about the fact that today's your day for ICD-10. And, frankly, one of the applications that we should think about is as you look at what you did for ICD-10 and what your culture in your organization has done, how you've gone through this transition, is a really good opportunity to think about the tools and the topics and the concepts that we're talking about today relative to where we go. So it really is important that you develop a culture that says we can and will improve our patient care, will improve our communication amongst ourselves, to our physicians, to our hospitals, to our referring sources, and that sort of thing. So it's really critical that we look at what our culture is all about. Now, Lean Six Sigma, just again by way of quick introduction, both are manufacturing principles. So one of the questions I very often get is, or comments is, well, you can't apply manufacturing principles to the medical practice. Well, I disagree with that. Because lean in and of itself is an idea that suggests that we waste a lot of time, that there are gaps, there are lags in what we do, and we're not very efficient. So one of the key words in lean is how can we become more efficient, or efficiency. In Six Sigma, on the other hand, we're talking about broken parts, and those broken parts could be medication errors. There could be a lot of different kinds of things. So how effective are we? And what we try to do with our session today, and when we talk about Lean Six Sigma, is to identify how can we apply these principles to the medical practice so that we can become more efficient in our delivery of care and more effective at the same time. And one of the things when I mentioned the idea of culture is that these are great tools, these are great ideas, but you can't just say, okay, we fixed it, and then wipe your hands and move on. The idea here is that you need a continuous effort to improve your processes as you go through with your organizational change, the dynamic that we have and as we face. So I want to encourage you to keep an idea in mind of what principles, what ideas that we have, but continually work to improve. A question I love to ask is, how much time do you waste? And when I talk about waste, I'm really talking about this particular slide, which in our packet here is slide number 15. We're talking about downtime as an acronym related to wastes that occur in your practice. So if we go through the downtime acronym very quickly, defects, medication errors, different kinds of things like that, dealing with the wrong patient, doing the wrong need, whatever it would be, overproduction, drawing too many samples, too many specimens, the wait time question. I'm going to skip that fourth one. Then transportation, moving samples, moving things around. And even on the bottom, we have excess processing where we're still moving things. How are we handling our patient flow? How are we in the motion idea? What are we doing to move things around in the office? And I think if you actually looked at how you go, pieces of paper, patients, staff, where supplies are, and so on, become extra steps. And what we really want to do today is to suggest that you can fix things not hours and days at a time, but minutes at a time. So when you're thinking about how I'm moving pieces of paper around or how patients are moving, then we're talking about what inefficiencies do we get. Now, and then the inventory, meaning do you have products and supplies that are unnecessary, that are occupying space in your office. The N word in the downtime example is not using employees skills and abilities. And I think this is the most important one for you to recognize, because as I said at the beginning, you can't fix all of this by yourself. You have to have this as a team. You have to have people working together on this. And we need to recognize that there are a number of skills that all of our employees have that would be appropriate for us to deal with. In fact, one of our metrics that we do is we recognize that 25% of our day is wasted. So if you look back at that downtime example, 25% of your day is wasted by doing those kinds of things. Key to Lean and Six Sigma, though, is the voice of the customer. So what we talk about here is how do we recognize, how do we deal with, how do we know that we're hearing what our customer wants. Many of us say, well, I know what the customer wants. Patient wants to come in, they want to get out, they want to be taken care of, da-da-da-da-da. Well, there's a lot of components that go through the patient visit. In addition to that, I think it's important to recognize that the word customer is used here because it's not just patients. It's fellow employees, it's hospitals, it's referring doctors, it's even the payers that we have to work with that are our customers. So how do you know what's necessary for them, and how do we know that we're dealing with things? Do we do interviews? Do we do patient satisfaction surveys? Do we observe what goes on? How do we communicate what that patient needs? So when we look at this, then, what we're really talking about is the idea, and I love this little symbol here where it talks about V equals R minus E, because what we're talking about with quality and value, because the customer wants value from the encounter and experience that they have. So a customer comes to you with an E, which is an expectation. If you meet that expectation, the R, which is the results, will be positive. If you don't meet that expectation, the R, which again is the results, would be negative. So what do we have here? We have a V equals R minus E, which is a great formula to post in your staff dining room, and you can talk about this. How did we do today? Did we meet that customer's expectation? Did we give that customer value for the experience that we had? In fact, if you go back to the downtime example, we can see that most of the encounters, most of the activities that occur in the practice really relate to us as individuals, not necessarily the providers. So how are we working together to see where we can make this happen? So I like this V equals R minus E as something you could post in the staff dining room or something like that. Now, so what is Lean and how does all this work? Well, if I like to look at a physician office visit, and you can do this with a hospital admission, lots of different kinds of things. But basically, a physician office visit has 5 steps. Has the check-in, has the triage, has the provider visit, has that immediate activity after the visit with the provider, and then it has the checkout. And I've got different words there on the screen, but this basically suggests that there are 5 steps. Well, if you look at this and take the idea of a manufacturing process, then what does manufacturing do? They go through an assembly line, and that's basically what we're talking about here. How does the patient move through our assembly line? Or if we looked at it in a different way, how does our encounter form go from point A to point B to point C? How does our employment application go? And so on. So there are a number of applications for this. I use the patient visit because that's the most important, the most critical part of where we go. So basically what I'm saying here is that these are the 5 steps that are necessary. Now, yeah, you could go to lab, you could go to an imaging, pulmonary function, different kinds of things like that as you are experiencing these things. But I think everyone would agree that these 5 steps are the most critical and most frequent. So as we go through this then, these 5 steps, this assembly line concept is where we want to go. Now, one of the things that's real critical with the ideas of Lean and Six Sigma is that we have some structured approach. And when I say that, I like to look at this as I like to use the concept of deployment platforms. In other words, there's a structure in place. So there are 2 deployment platforms that we like to use. The first one is an option called DMAIC, which is define, measure, analyze, improve, and control. So you define what your issue is, You measure what is going on and how that works. You analyze what your measurements are telling you. Then you work toward coming up with a solution to improve the processes that you have, and then you can control it. So as you think this through in your daily life, most of us do a very good job with the measure, analyze, and improve. Where we have problems in our structured approach using a deployment platform is we have difficulty in defining the problem. Because typically what happens is we see a problem, and all of a sudden the problem becomes so large it goes beyond what our initial scope was, and we define it then as project creep. The project becomes so big, or the problem becomes so big, that we can't fix it. So the idea here is to define and to focus in on a small win-win, a small area, and focus on how you can measure that, analyze it, improve it, and then control. So the second piece of this 5-step deployment platform that we don't do well on is control. And when I say that, a lot of times many of us will say, okay, let's go fix this. So you'll come up, you'll talk to the employee, and you say, boom, let's do A, B, C, D, E, da-da-da-da-da, everything is good. And then we think that it's been fixed and that things have changed. We don't go back 2 weeks later and check it out to make sure that what we talked about, the new way of doing things, is right, or have we fallen back into, oh, we've always done it that way. So the idea is let's identify a problem, measure it, analyze it, improve it, come up with a better way of doing things, and then make sure we reinforce and control and actually change how we've approached things. So this organized process is what we're talking about. The second deployment platform, which many of you may have heard of, it's more popular in our world, is the PDSA, which is the Plan, Do, Study, and Act. Now, the plan actually takes the define, measure, and analyze steps from the DMAIC and puts that into one bucket. Then you improve or do, but you do with what we call a pilot study or a pilot test. And so when we do that, we identify how are we actually going to fix this, but let's test it before we implement it across the practice or with all of our doctors or every day of the week. And we look at our analysis of our pilot project by doing a study or checking on it, and then we act, which is the control phase. So I don't care which deployment platform you have, but I do encourage you to look at how can we come up with a structured approach that would work within our culture of our organization to make sure we move forward with where we're headed and how we want to go. So you're going to do this with a project management team. And when I say project management, what I'm really identifying here is that a project has a beginning and an end. So we take our deployment platform and we say, okay, we're going to define the problem, we're going to end the problem, we're going to act on it. That is a project management process, but you can't do this without doing it as a team. And I'll talk a little bit more about that in a minute. But I just want to emphasize the idea of project management as a great way and a good tool for you to use, or a good concept for you to use as you move forward. Now, okay, so let's talk a little bit about some of the tools that we have. And one of the key tools that works really well when you're doing an analysis of the process work we just identified, such as that patient flow, is if we look at this process map. Okay, we've got check-in, we've got triage, provider, the post-activity, the checkout, and so on. But what the picture is telling us is there are different symbols. So the oval, which is a start or an end, a rectangle, which is the process itself, the diamond is a decision. So what I like to think about, and some people get critical of me when I say this, but process or policies and procedures are great. But when do you look at a policy and procedure manual? About every 3 years when the inspectors come by. Whereas if you had a tool where you actually mapped out what each step does in your process and you had a picture, you would have something that could be but very dynamic because it can be worked on to improve, but it also becomes a great tool for you to use in terms of training and orientation or onboarding your staff. Now, the symbols that are there are important when you come to finalizing your document and putting it together. So when I put this particular slide together, I did this in PowerPoint. It's not complicated to work on. You don't have to go out and buy a special process map, flow charting, project management software. There are tools that you have in your office are already available. But you can also do something like this, which is what I call a brown paper exercise, even though I got white paper for this example. But if you went to an office supply store and got your brown wrapping paper, put that on the wall, and then got a team of folks together and say, okay, let's identify what we do. So what goes into the check-in? What goes into the triage? What goes into the provider visit? What goes in, different things like that. So what I had in that previous slide was the big picture. Let's break that down and say, okay, I think we've got a problem in our triage area. How are we going to fix that? So what are we going to do? So what you would want to do is maybe get 1 or 2 or 3 of your medical assistants, your triage team together, and say on a yellow sticky, and I use yellow and pink in this example. You don't have to, but if say on a yellow sticky, write down what you do. So that yellow sticky you put up there in a rectangle or a square, and it looks like these are the steps, the processes that we do. The pink sticky note is a diamond, so that's where a decision is made. So if a patient is in the triage area and we're having trouble getting blood pressure, the temperature is elevated, there's a different language that we have. Those would be points in time where decisions may have to be made in between the steps that we have. So I've actually put then several steps on this chart, and then several steps or points where decisions have to be made. So how does this work? Well, the team gets together and says, let's identify what we do at each one of these steps along the way, and uses this brown paper exercise. And we use brown paper because if you'll notice in between each of the sticky notes there are lines. So we're connecting step 1 to step 2, decision 1 to step 3, whatever happens to be as we go. So you don't want to do this on a wall. You want to do this on a brown paper. Now, another key tool, you've got a smartphone. Take a picture of it. So you've got that to memorialize what you've done. First step in your process mapping is a current state. What do we do now? Once you've done that, you can go into another very interesting tool, I think, which is a VSM. Well, what's a VSM? A VSM is a value stream map. And so if you look at our 5 steps that we talked about before, and I've put those in the gray on this, and go and you say, okay, well, I've now said another question. What is my cycle time? How much time does it take for a typical patient, say a 99213 routine office visit patient? How much time do they typically spend in the office? Well, if you look in the bottom of that chart, it shows 91 minutes. So from check-in to check-out, the cycle time in this particular example is 91 minutes. Well, that's pretty easy to find, and it's a great question to ask, because if you go back to downtime and wait, when you do a patient satisfaction survey, what do you find? Most frequent issue is wait time. So a cycle time, looking at the actual time that a patient spends in the office, gives us what? It gives us a measure. So we've defined our problem as how are we going to manage patient wait time? What do we want to do with our measure? Well, let's measure our cycle time. So we've got 91 minutes in our example here. Then I said, let's look at this a little bit further. And many of your practice management softwares, your EMRs in particular, will help you by giving you checkpoints as you go through the cycle. So with the black numbers on the left-hand column there, I see 4 minutes for check-in, 6 minutes for triage, 14 minutes for provider, 13 minutes for the immediate post activity, and 7 minutes at checkout. So that's a total of 44 minutes. But I said there was 91 minutes. Well, there's 47 other minutes that are identified in the red, 32, and so on and so on and so on. So a principle then in this value stream map, and back to our value equation that we had for our customer, the customer typically wants to pay for the value that they receive. Anything that is not value added is called non-value added or waste. So in our particular example here, we have 47 minutes of time wasted. We have 44 minutes of time where the customer is getting some value. Now, we've added a business value add, which is the 4 minutes for check-in and the 7 minutes for check-out, because the customer typically wants to have what? They want to have an experience with the medical assistant, the nurse, with the provider, and that's what they're looking for. The receptionist and the checkout team, I can do with or without them, but the business can't. So that's business value add. So as we think about our cycle and trying to identify what our flow is, the 91 minutes then is broken down into 44 minutes of value add, things that are necessary for us to do, 47 minutes of wasted time. And what we then have is our process cycle efficiency measure. And so in this example, 48.3% of our visit is what we would call efficient or value add. Better than 50% of our time then is wasted. So when you were going to say, okay, let me look at this, where would I've got a very interesting kind of picture here, and it's telling me I've got a lot of wasted time. So here's a trick question. I ask you, where would you actually want to go to see what you could do to save the most time? Everybody jumps on the wait time. Well, the wait time because it's big. Well, the wait time in the waiting room or the reception area, you can't really do much there. But if I look down and I see 8 minutes between triage or between post-visit and checkout, I see 3 minutes between provider and post and so on. I see some different times there that would seem to me to be, well, what's causing that bottleneck? What's causing that gap? What's causing that delay? So what can I do then? If I were to analyze this, I would want to look maybe at those areas first. I might also look, frankly, at a value add time, which is that post 13 minutes. How come it's taking 13 minutes after the physician has or the provider has actually seen the patient? Is that scheduling procedures? Is that complications with ordering prescriptions? What is it that's causing a problem that delays that? Now, what would happen is if I fixed either that gap time, say that 8 minutes, or if I looked a little bit at that post 13 minutes and was able to fix 1 or 2 things, by the end of the day, I might have gained 2 or 3 minutes per visit because I fixed that. If I saw 20 patients in a day and I gained 2 minutes per visit, I would then have what? I would have 40 minutes. I would have cut additionally then wait time out because it exponentially affects the wait time that I have. So if I gain, say, 40 minutes or 2 minutes on each patient visit, 2 minutes on 91 doesn't sound like a lot, but if it was 2 minutes on every single patient and I saw 20 patients, I would have gained 40 minutes in that day. And that 40 minutes could mean I could see another patient or 2, or it could mean that I could get home on time, depending on what my motivation was. So my point is that by actually sitting down and defining this and then measuring it and then analyzing it, what I'm doing is I'm looking at this and saying, okay, where are my gaps? Where's my problem? It's not in the waiting room, but it is in my cycle that I have here. So by looking at my cycle time, 91 minutes, by looking at my value add time, which is 44 minutes, by looking at my non-value added time, 47 minutes, my process cycle efficiency, I've gotten a lot of measures all of a sudden that give me an opportunity to improve. Now, when I ask the question many times about what's your cycle time, I very often hear things like, oh, it's about an hour, or an hour and a half, or it's about this. Well, how do you fix an about? In this example, if it's 91 minutes and I cut 2 minutes off or I cut 4 minutes off, I actually then can prove that I've improved the process that the patient is experiencing by that by that way of measuring. So it's very important for us to use some metrics. It's very important for us to measure what we have. So we've defined a wait time issue, and now we've looked at how we can measure that with our value stream map. So the measure idea becomes very, very critical for us. We need a benchmark. We need a baseline. So one of the things you could take away from our session today is let's go see what our computer says, or let's do a log in, log out for check-in, check-out for any patient that comes into the office and begin to see what goes on as to how and where we go with that. And so when we think about this, two key principles on the measure thing is if you don't measure it, you can't change it. Again, if it's an about or a specific, I can working on the specific. But if you don't value it, you won't change it. In other words, if you don't identify the need for and the benefit for doing this, you won't do anything to make a change in your processes. So if your customers have complained, you will be able to then say, how much time does it take? What have we done? Another example, outside of the customer flow, what's your denial rate? What is a denial? Well, a denial is a waste of time, in my opinion, because it's a claim that did not get paid. Well, is it something that we did wrong, or is it something that the payer did wrong? If it's something we did wrong, we can fix the denial rate. Well, how important is that? Well, that means that we improve cash flow, means we don't waste our time redoing work that could have been done right in the first place, and that sort of thing. So we have to measure that. We put value on it, and then we know that our denial rate was, say, 15%. Now our denial rate's down to 12%. We can then say what? We have improved it. We placed value on it, and we improved our process that we had and where we go. Another fun tool, if you take all of your patient cycle time and just list them on a spreadsheet, and then do what we call a run chart, which is, and this is the example that I have on the screen is actually a control chart, but let's back up for a second and see the squiggly line. That's a run chart. That's just simply tracking check-in, check-out time for patients on one day in a particular practice. Well, this control chart gives us a really good tool for us to say, well, what are the parameters within which we think we can and would accept our patient visits that we would want to have. So what the control chart does is it sets an upper control limit and a lower control limit based on our average time that patients would be in the office. So in this example, our average time is about 62 minutes. Well, let's say we made a decision that we wanted to have, and we recognize that not every patient is exactly the same. So we have a parameter within which we would like to see patients. So let's say it's a 10% variance off of the mean. So if we have 62 minutes, it's roughly 68 minutes is our what we call then the upper control limit, and 56 minutes would be the lower control limit. So how many patients actually fell within those control limits? Well, in our particular example here, not very many. But wouldn't that be a great way for you to say, how well are we doing with our overall patient flow? In addition to that, when we do our run chart, what our run chart will help us do is that any patient visit or any denial rate or anything that we want to apply this to that falls outside of our control limits, we need to look at. We don't need to worry too much about the patients that fall within our control limits, but let's figure out why patients are outside. Well, as I said earlier, one of the problems we have is defining our issues. Well, our example here is not only new patients or established patients, it's new patients and it's injections. Well, maybe what I should have done is defined our problem as I want to identify what we can control and how we can improve our established patient visit time in the office. So what's our cycle time for established patients, not just all patients? So as you can see, if we would have taken that 157 minutes out for a new patient, if we would have taken the 20 minutes out for the injection, which would have been the patient on the last patient on the right, if we'd taken those out, we would have had a lower or a better control point. But also by simply doing this, we can say, well, how come there's 150? Well, that's a new patient. We didn't actually need to keep that. We don't drop that. But if we just then had established patients and we still had a squiggly line, a run chart that looked like this outside of our control limits, we got a problem that we have to take a look at and see where we go. So this is a good graphical way of looking at your processes that you have. So we basically talked then about process maps, value stream maps, taking a look at a run and control chart. Another very good tool for us to use is something called a fishbone diagram or a cause and effect diagram that we have here. And what I'm talking about is, and this really is a tool that works very well for a lot of other aspects of your practice, because on the right-hand side is the effect on the left-hand side with the spine and then the fish bones coming off, helps us identify what are the causes that created the effect. So what we then said in this example is we wanted to look at long wait times for new patients. Well, what are the causes for that? Is it the processes that we have? Is there something to do with the patients that we deal with? How about the payers and authorizations that we have to deal with? Or maybe it's the practice itself. Maybe we have some policy issues that are not consistent with where we want to go. So what you can do is, and this works well. We've seen this work well with credentialing reviews. We've seen it work well with a lot of that kind of administrative functionality, not cycle time, but working well with some of the administrative kinds of issues that you have in your practice. So what is the effect here? The effect is that we didn't get one of our doctors credentialed timely. Well, what was the problem with that? What caused that? So instead of doing a flow chart, we did a cause and effect diagram. You can do this cause and effect diagram in the same way that you did with your process map by using sticky notes. So you can get your team together and say, how do we make all of this kind of work, and where do we go with it? So that's all. So another tool. Now, the emphasis on this idea, again, the team that we have. If you were to say, okay, I've got a problem, cycle time, denial time, credentialing, approval of processes, different things of that nature, what am I going to do? Well, I'm going to have a team. Well, my team members are going to be these types of people. Champion. One of the key goals here is to identify one of your providers who will be the champion, believes in the idea that we can improve. A team leader, which will probably be more likely than not many of you that are on the call today. Process owners are those that actually do the work. And then SMEs, subject matter experts, can be either inside or outside of the practice or inside or outside of the process itself. And I'm going to give you a brief example on this in a couple of minutes. And then finally, the other team role is to recorder, because what you want to do is you want to document. You want to create a playbook. So what I hope you'll do is you'll do the PDF and print the slides that are here for today, and that'll become the beginning of your playbook. And then you'll be able to say, okay, I had this session, I had this meeting, I did this, did that. You record what you did in terms of your activities that occur. So you're going to assemble a team. So one of you would be the team leader, and then you're going to say, I want 2 or 3 people that actually do the work, and my SME might be, say, an IT department person or a contracted data processing people, something like that. And so I've got a 4, 5, 6-member team that's now trying to analyze what goes on. Well, in teamwork, one of the things we have to be careful about is that we have 4 different stages, which means we form it. So you've made a decision. You've selected the members of your team. Well, typically what happens is there's storming that occurs. That means there's arguments and issues amongst the team members, because I don't like the way you part your hair or whatever it happens to be. But you as a team leader will recognize that there are storming stages. Then you go to the norming where, okay, we've gone past the storming and now we perform, which means we're actually getting into analyzing and looking at how and where we go with our material that we have. So let's think about this for a minute, and we'll do a little PDSA. So on our front desk, our problem is management of referrals, okay, because referrals are difficult for us to deal with. Well, who's our customer? Well, our patients are the customers. Our referring physicians are customers, even our fellow employees. So who are you going to put as your team? Well, one of you would be the team leader. We would look at our process owners as, let's say, 2 receptionists and a medical assistant, and maybe a billing coordinator, because all of that might have an impact on managing our referrals. So that becomes our team, our process owners. Maybe one of our SMEs might be, again, an IT person, because we're talking about how we use the computer, how we use the practice management, how we interface with the EMR. We create then a process map. So we do a brown paper exercise. So we sit around in a conference room and write down on a yellow sticky note everything that we do. And everybody writes it down. Well, what will happen is that we'll end up with the two receptionists saying basically the same thing, but they may do it at different times. They may do it in different ways. Well, those are the kinds of contributory issues that would help us look at and say, that's where we have a problem and where we go and how we want to do this. So what are we going to do? Well, why don't we log the time that we get that initial phone call to the actual time that the patient visits and see where it goes. So let's do this for a week. So our plan is we're going to do all of this kind of stuff and see where it goes. Well, as we've gone through our plan in measurements and our analysis, we've actually come up with an idea that we want to see what we can do. So the team has said, let's just have one person become our referral manager who handles all aspects of what we do. And that could have been again, an outcome. So let's test this out, but let's only test it out with Dr. Smith. And Dr. Jones and Dr. Black and Dr. Green we won't use them because Dr. Smith actually is our champion. He's the one who believes in this. So we'll do our pilot test for 1 week and see what happens. Well, in our study phase, we recognized that, wow, that one person still had way too much to do. It was difficult to prioritize what we had. We had forms that were there that we had too much information and we didn't have the right information in a couple of cases. It was difficult to communicate with the other offices. It was difficult to talk to the billing staff who were the ones who were doing the verifications of the insurance. In other words, we had this idea in mind, but we still ran into some problems. We reviewed this, and once we've reviewed it, then we've developed and revised our approach, and now we've come up with our solution. So we've revised our job description, we've got a designated phone line, we've reviewed the process, and we put process maps together, and now our process map is not our original state, it's now our current state or our new current state or our future state, depending on how you want to define that. And so what we also said is, this is a really neat thing, and what we want to do now is we've got to roll it out with all 4 of our doctors. And what we'll do is we'll agree that on the 1st of November, we're going to get together and we'll look at this again and see how it's done. So we've actually gone through our structure. We did a week's worth of data to try to identify. We spent another week trying to go through how we would solve the problem. We did our pilot test, and now we're ready to go. So in 2 to 3 to 4 weeks, we've actually fixed what was a monumental problem of managing our referrals. And so that may sound like it could be a very basic kind of way of looking at it, but I hope you get the idea that if you have some structured approach and then you record this as you go through, you're going to be able to use this and implement it in many different ways. Now, a couple of other things that are really easy. So here's a very simple tool. Because if we go back to our cause and effect, our fishbone diagram, you can ask a simple question: why did this cause have this impact on our effect? So a 5 why process is very simple. Just go up to an employee tomorrow and ask them, why are you doing that? And then see what happens. Well, why am I doing that? Because I was told to do that. Well, why are you doing it that way? Because that's the way I was taught. Well, why were you taught that way? Because that was the way Jane taught us. And then the person is going to say, well, who's Jane? Jane was here 5 years ago. And so the idea is, instead of always doing it the way we've always done it, if we get people to understand why they do it in the way that they're doing it, we may have some really interesting kinds of outcomes. So here's a simple example that I have on the screen, and I like to go through this because, when your child comes home with a D in math, and the reason they got the D in math is because they didn't do the homework. Most of us, and I say most, I don't mean everybody, but most of us will stop and say, okay, no screen time, you're grounded, you can't go out and play with your friends, you can't do anything until you get your homework done. That solves the problem. instead of saying, well, why didn't you do your homework? In other words, the second why is, why didn't you do your homework? Because I hate to do it. The next why is, well, why do you hate to do your homework? Because I suck at it. Why do you have this math issue? Because I suck at it. Well, why do you suck at it? Because I just don't get it. In other words, by drilling down and asking why 1, 2, 3, 4, 5 times, and we use the 5 why as an example because typically, certainly by the 5th why, you've got the answer. Here we would want to do, instead of grounding the child, maybe we need to spend more time, maybe we need to get them to a special tutoring program and so on, rather than force them and punish them to do the homework. Same kind of thing can happen with an employee that we have in the office as to where we go. So I love this 5 why tool. And this is something you can do even without the deployment platform. So I'm saying, gosh, you don't have to have the deployment platform. Well, that's true to a point, but you can use the 5 whys as you go through the steps. When you develop your process map, when you develop your cause and effect diagram, you can ask these questions as to why it's being done that way. And that will give you a lot of really cool information on how we go. Another interesting tool is the 5S. Some people call it the 6S, but let's just go through the 5S. Because one of the fun questions that I ask is, how many of your exam rooms are exactly the same? How many of your nursing desks, nursing stations are exactly the same? In other words, when I go into an exam room as a provider, if I were a provider, where would the gloves be? Where would the tongue depressor be? Where would the alcohol wipes be? If they are always in the same place, then I would know that my material, where my material is, I don't waste time looking for those things. So what I do first is I sort out, what do I need in the exam room? What do I need at the nurse's station? What do I need at my desk? What do I need at the front desk of the reception area? Okay. Once I've done that, then I set it in order. So I put it in the same place and I always have it in that same place. Then I keep it that way. So I've cleaned off the desk. I've cleaned off the area. I know where it is. I've become more safety conscious. I've become aware of the waste that's there. Then I standardize it. So I go from room to room to room to room, or desk to desk to desk to desk. And I make sure that I follow through on that, and then I sustain it, which means that it's always done that way. So every day there's a checklist that's created that says these are the items that are in the exam rooms, and there's a picture drawn that says these are where they go, so that I sustain it and keep reinforcing that activity. So the 5 whys, the 5S, they're simple applications of solutions toward where you can go to help you with either identifying your problems or solving your problems and how that fits. So back to the whole point here. Let's start with commitment. I'm hoping that what you've done is that you've gotten a quick, brief picture of the deployment platform, some structured approach with some tools and some ways of saying this, but you have to have this commitment. What's your mission statement say about improving or providing patient care? So if you've got commitment, if you found a good champion to help you, you can be moving forward with that. So take a look at your practice. This particular slide, slide number 39, says, what's our readiness assessment? Are you ready to do this? Can you take from today and take an idea and try to move forward? You have to ask yourself that question. And then another thing that's very important is to recognize that it's okay to fail. And I mean this very sincerely, because if you don't try something, you don't know whether it's going to work. And it's okay to fail. That definition of craziness is to continue to try to do things over and over again the same way within expecting different results. Well, what we want you to do is we want you to take one of these ideas. We want you to think about in your practice, what can I do? How can I make and move forward to become more efficient? Let's try it. If it doesn't work, fine, because we tried it, but we also learned. So we recorded what we did, what went right, what went wrong. We learned from that, and then we tried it again in our continuous process improvement idea. So we've moved forward with this. So I'm hoping that if you say it's okay to fail because we tried and we made improvements, and what we ended up making improvements as to where we go. So how does all this work? I've mentioned denial management, I've mentioned credentialing, I've mentioned some administrative things, hiring and firing processes, I've mentioned the patient cycle time. There are so many applications that you can use in fixing this kind of thing. And so if you would say, okay, here's a problem, I like this tool, let me use this tool, because we've seen significant improvements in average cycle time. I've actually got a practice now that we see patients in a primary care practice no more than 35 minutes. We've seen improved patient customer satisfaction survey results, and that means getting more and more improvements and are going from 95 to 95.5 to 96% improvement ratings as to where we go. We've seen elimination of duplicate duties. And one of the things, as I said, is a waste is the not using employees efficiently. What we've been able to do is instead of having an employee sit there and do routine, basic kinds of things because somebody else didn't do it right or because the same piece of paper has, or two different pieces of paper have the same question. We've eliminated some of those things. What we've then been able to do is challenge the employees to help us continue and work toward improvement. So we've eliminated duplicated duties. We've eliminated those wastes of time. And in eliminating those, what we've actually been able to do is utilize employees more efficiently, which has led to what? Improved cycle time, which has led to decreased denial time, which has led to improved patient satisfaction. So we've been able to get employee satisfaction up to a great extent. We've increased then our efficiency. And now as we think about pay for performance, we think about all of the different kinds of things with the value-based payment modifier, we've been able to then get more focus on what's become more complex ways of doing things and seeing some significant improvements then as to where we go. So I think that if you actually take this and say, okay, yeah, he talked about cycle time. Well, that's only one part of it. There are so many applications, so many measurements that we've seen that have led to some significant improvements. And I like to look at this because improvements in the typical organizational structure start at the top. Well, that's not the way we want to do this. We want to have you encourage, get all of your employees involved so that you seek to find and do things to improve patient care by getting everyone involved and starting at the bottom. So what I hope I've done in this brief time we've had together is to suggest that I'm hoping you're triggering some thoughts. Now you need to do it. Now, just as a side, some of you, I hope, I'll be able to see at the MGMA conference, the annual conference in Nashville in a couple of weeks. I know PerfectServe has a booth there. MGMA, of course, has booths. I will be in the booth at the MGMA consulting booth. Would love to chat with you about today's session, about where you are, and maybe help encourage you a little bit more to utilize these tools. And please feel free to reach out to me at any time if you have some questions. Because my goal here is to improve patient care. And I believe that if you take a structured approach, you will be successful in improving that patient care that we all want to have and all want to take a look at. So I think that completes my portion of the program. And I'd like to turn it back over to the team and see if we've got any questions from any of the participants or any of the audience.
Great. Thank you so much, Owen. Before we get into questions, I just wanted to remind folks about obtaining your certificate of attendance for today's event. By attending this PerfectServe-sponsored webinar, you will receive continuing education credit from MGMA if you are a Certified Medical Practice Executive, CMPE nominee, or FACMPE. If you would like to receive a personalized certificate of attendance after today's webinar, again, please let us know via the survey shared at the end or send an email to webinars@perfectserve.net. After receiving your certificate of attendance, you must log your own credit hours on MGMA. Now next, there are quite a few questions that have come in for you, Owen. We will go right to around the top of the hour, and I know that you have agreed to answer any questions via email that we don't get to, so thank you. We appreciate that. Owen, the first question is, do you always consider the registration time and the triage time as value added? In our current project, we are considering that as a business value added.
Well, I think let me put it this way. I think the check-in time is business value add. That is time that's absolutely necessary for the business to continue to function. The triage time, I think that's more value add, even though the patient may not recognize it. It really relates to the reason that the patient is there. So it's more clinical in nature. So I like to think that that is not necessarily business value add. That is more a value add component. So when I look at value add, that would be, say, non-business value add, I think there are 3 steps. That's triage, the provider encounter, and then that immediate activity such as prescription refills or scheduling tests or so on. And in addition to that, outside of that basic cycle, some value add time could be, getting lab tests done and different things like that. But when you do those kinds of things and go outside of that basic cycle, you could end up with additional wastes of time, non-value add time, because the patient has to wait. So, specifically to answer your question, business value add, I define it as check in and check out. The value add is the clinical activity that goes on.
Great. Thank you so much. Next question is, do you have benchmarks for the length of time that different visit types should take? Some previous research we used in total visits should be 1.5 times the time the provider spends with the patient. Would be curious about your perspective.
That's an interesting point. There really aren't any national benchmarks that I'm aware of that tell us what that is and where that would go. And so I think that your 1.5 metric would be fine. One of the keys is that you should develop your own internal benchmarks as to what Dr. A, B, C, D, and E do, so you know what your total cycle time is. Then you can look at your value add time as to where that goes. But using the provider as your baseline can be good and can be bad, because in some cases you've got providers that frankly waste a lot of time in the office because they're scrambling around. They're not very organized in their questioning and thought process. They spend more time socializing than they wouldn't say normally want to do. So how you would measure that, develop that metric is something that I would have to, spend in your office. You'd want to spend more time on and compare doctors one to the other, as well as the fact that, I would like to encourage MGMA to develop a cycle time benchmark by specialty, because it also makes a big difference on, if it's a follow-up post-surgical visit, that only takes a couple of minutes or, doesn't take quite as long as a new patient visit or established kind of review that you would have. So I love what you said. I like your thought process. There are no national benchmarks as to where that would go.
Great. Thank you. Next question that came in is, and this will probably be our last question, maybe one more, is does this model vary depending on the type of physician, primary care versus urgent care versus surgical or medical specialist?
The model itself doesn't vary because the principles are all there, very stable, and that's identifying I need to define my problem, I want to measure what my issue is, I want to analyze, or I want to plan, I want to do, I want to study, I want to act. So you need that deployment platform. So the model doesn't necessarily change. The application of the model to your environment could be there because you may have in a urology visit, you always have to stop and provide a specimen. So there's an extra step there. So by specialty, by type of practice, the steps that you might be going through using our patient cycle, would be different. But if every specialist has an encounter form or an encounter, so they have one measure as to where it goes. They go through a clearinghouse. They go through da-da-da-da-da. So when you start to get outside of the patient cycle time, you look at some of these other administrative functions, and they're going to be very much the same regardless of specialist.
Great. Thank you so much. And Owen, that brings us to the top of the hour. As I mentioned, there are some questions that we did not get to today, but that you were willing to answer those in email, and we will send that out with the follow-up. So thank you so much. I also wanted to share with you the next few events in our webinar series. Our next webinar is scheduled for November 5th, where David Katz, Principal and Executive Director of the Advisory Board Company, will share his knowledge on the Shared Accountability Care Model. On December 2nd, Dr. Joshua Bennett is back by popular demand to take a deeper dive with us on the patient-centered medical home model, breaking down the 10 critical steps towards transformation. As always, PerfectServe Thought Leadership webinars are free, so please register by visiting PerfectServe.com and clicking on the Knowledge Center tab. And as Owen mentioned, we will be at MGMA in about the next 10 days. We look forward to meeting some of you in Nashville. Please stop by and see us in booth 730. And if you would like additional information on how PerfectServe cloud-based communication system can help your hospital, practice, or system streamline communications and improve operational efficiency, let us know using the poll feature located on your screen. I'd like to thank Owen for an amazing presentation today, and also thank you to our audience for joining us. Please take a moment to complete our short survey and tell us how we did, and everybody have a great afternoon. Thank you so much.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating. You may now disconnect.